So based on the last version of the NCCN guidelines, at diagnosis, what we have to do is to identify patients fit for an intensive approach, and differently from those who are not candidates to receive an intensive treatment. When we say intensive treatment, we mean a lot of options, but the very first one today is represented by Tagraxofusp, which is an anti-CD123 drug, which has been approved by FDA in 2018, and then by EMA in 2020. In particular, in Europe, it's approved for the first line of adult patients with BPDCN. Other options include standard chemotherapy based on AML or ALL regimens, or non-Hodgkin lymphoma regimens. But what we know is that with standard chemotherapy, unfortunately, the duration of responses are very, very short, and only a minority of patients are able to proceed to an allogeneic stem cell transplantation, which is the final aim of our approach. Because with whatever is the treatment we decide to start, the aim is to achieve a CR and then to proceed to an allogeneic stem cell transplantation, of course, for those patients who are fit and eligible for this kind of approach. Together with these treatments, we have to perform CNS prophylaxis, as I mentioned before, with lumbar punctures. So at the moment, I must say that the best approach we have in order to achieve the higher rate of CR is Tagraxofusp, and based on the data which have been published in the New England and then in the last follow-up in JCO, the overall response rate is 75%, so the majority of the patients are able to achieve a response.